Thank you, everyone, and thank you for that introduction. I will be talking today about the practical and clinical considerations of implementing long-acting antiretroviral therapy. So the outline of my talk today will be, firstly, to introduce the need for long-acting antiretroviral therapy. I will attempt to summarize some phase 3 clinical trial data around long-acting cabotegravir and rilpivirine, and then talk about the bulk of my presentation today, which is going to be on the clinical and practical considerations of long-acting cabotegravir and rilpivirine, and then touch on lenacapavir for treatment-experienced patients, and finally conclude by talking about access and equity to long-acting antiretroviral therapy. So where are we with long-acting antiretroviral therapy currently? So currently we have 3 drugs at the moment. So long-acting cabotegravir, rilpivirine, lenacapavir, and ibalizumab. So just to start off, long-acting cabotegravir and rilpivirine was approved in January of 2021 to be given intramuscularly either every 4 or 8 weeks. And then we have lenacapavir, which is the first HIV capsid inhibitor, which is given subcutaneously every 6 months and was FDA approved in December of 2022. Ibalizumab has been around since 2018. It's a monoclonal antibody given as an IV infusion every 2 weeks in those patients with virological failure. And then we have the return of islatravir, which restarted in September 2022 as a weekly oral combination treatment regimen. So why the need for long-acting regimens? Well, clearly there is a need because it offers less frequent dosing and avoidance of pill fatigue. It increases the choice for both patients and providers, and often a recurring theme in qualitative studies by end users are that it avoids HIV-related stigma and the daily reminder of having HIV, which is important to patients. It is more convenient for work and travel purposes. And when there is an indication where patients cannot take oral antiretroviral therapy, such as malabsorption or dysphagia, long-acting antiretroviral therapy fills that need. It eliminates gut-based drug-drug interactions and food effects, and has the possibility in the future of being co-formulated with other long-acting drugs. Clearly, cost and resource considerations top the list of challenges, as do the need for additional clinic visits every 2 months or so when patients are now used to coming back every 6 months. The injectables at the moment cannot be self-administered. They have to be administered by a healthcare professional. They have relatively large injection volumes, and one of the more common side effects, injection site reaction. There are knowledge and research gaps for other populations, particularly around pregnancy and breastfeeding. There's emerging data around coming up in adolescents, as well as resource poor settings. And of course, there are issues around managing drug-drug interactions, and all treatment trials so far have only included patients with optimal adherence. What does the phase 3 data of long-acting cabotegravir and rilpivirine data show? And this is summarized basically in a nutshell. The Atlas and FLAIR studies have found monthly long-acting cabotegravir and rilpivirine injections to be non-inferior to oral antiretroviral therapy, up to 96 weeks in Atlas studies and up to 124 weeks in FLAIR, amongst individuals without baseline resistance mutations or hepatitis B co-infection. The Atlas 2M looked at 2 monthly cabotegravir rilpivirine and was found to be non-inferior to 1 monthly long-acting cabotegravir rilpivirine, up to 3 years of follow-up. There is a small but real increased risk of virological failure, which occurred in about 2% of patients with emergent 2-class resistance with the 2 monthly regimen. And this with the 2 monthly regimen, which comparatively occurred less than 1% on the monthly regimen, despite perfect adherence and no delayed injections. And this needs to be reflected when we counsel patients regarding long-acting antiretroviral therapy. The FLAIR extended study showed patients who were virologically suppressed on the back of a 3-TC and dolutegravir switching to long-acting cabotegravir and rilpivirine without an oral lead-in had similar virological suppression rates and adverse event profiles to those who switched with an oral lead. And these findings are summarized and reflected in the table here. SOLAR study, which was a more recent study in CROI 2023, looked at patients who were receiving TAF, FTC, and bictegravir, and who were virally suppressed on this regimen, and were randomized to one of three arms, either to continue TAF, FTC, and bictegravir, or randomized to long-acting cabotegravir rilpivirine preceded by an oral lead-in or a direct-to-injection. And looking at the graph on the right, we see that month 12, so these are responses at month 12, long-acting cabotegravir and rilpivirine had non-virological efficacy to TAF, FTC, and bictegravir, so of about 90% compared to 93%. 3 persons in the long-acting cabotegravir rilpivirine arm developed confirmed virological failure, however, with resistance versus none in the bictegravir F-TAF arm. So once again, reflecting the very high barrier of genetic resistance to oral integrase inhibitor-based therapy with bictegravir. Looking at treatment preference at month 12, and this is amongst 425 patients who switched to long-acting cabotegravir and rilpivirine, 90% preferred using long-acting treatment compared to 5% preferred oral bictegravir, TAF, and FTC. And we can see on the right lower hand that HIV treatment satisfaction scores improved as patients on long-acting cabotegravir and rilpivirine from baseline to month 6 and finally to month 12. Looking at long-acting cabotegravir and rilpivirine in terms of regulatory approvals, it first received regulatory approval in Canada in March 2020 and subsequently in the United States in January 2021. And then February 2022 was expanded the label to 2 monthly. In this part of the world, Australia received approval in May 2021, but only for the 2 monthly administration. Guidelines recommending which patients can be started or switched to long-acting cabotegravir and rilpivirine we can look at several guidelines, of which BIVA has been one of the more comprehensive guidelines. So this criteria for eligibility include viral suppression for at least 6 months, no previous treatment failure or unplanned treatment interruptions, or no known or suspected resistance to NNRTIs and integrase inhibitors. BMI has to be less than 30, and their subtype has to be non-A1 or 6 subtype if baseline resistance is unavailable. They can commit to they need to be able to commit to 2 monthly attendance for injections, and more importantly, accept the risk of virological failure and resistance despite complete adherence. And this sometimes can be very hard to explain to patients. Monitoring, they're required to have 2 monthly HIV viral loads, and they do not need and they should not require tenofovir containing regimen for treatment or prevention of hepatitis B. These are similarly reflected in the DHHS guidelines. The BMI requirement is not so strict in the DHH guidelines. They're more permissive, allowing longer 2-inch needles. Virological failure for long-acting cabotegravir and rilpivirine, and this is from a post-hoc analysis of the Atlas-FLAIR Atlas 2M studies, showing a rate of a failure of 1.25% with confirmed virological failure. The predictors of this include a BMI of greater than 30, a baseline pro-viral rilpivirine resistant associated mutations where the odds ratio was greater than 40, so significant predictor of virological failure. HIV subtype A1 or A6, and low rilpivirine levels at week 8. And you need a combination of 2 or more baseline risk factors for increased risk of virological failure. Moving on to practical considerations when using long-acting cabotegravir and rilpivirine. So they come in these initiation injection kits, or the 2 monthly injection continuation kits contain 2 vials of a higher dose, a long-acting cabotegravir 600 milligrams in a 3 ml vial, and a long-acting rilpivirine 900 milligrams in 3 ml. And you have 2 needles, 23 gauge and 1.5 inches. So for the 1 monthly dosing schedule, you administer 600 milligrams of long-acting cabotegravir and 900 milligrams of rilpivirine. And then subsequently, at month 2 and beyond, you administer a lower dose of long-acting cabotegravir, 400 milligrams, and rilpivirine at 600 milligrams. For the 2 monthly dosing schedule, you initiate injections of cabotegravir with a loading dose, or the initiation dose of 600 milligrams, and rilpivirine 900 milligrams monthly for the first 2 months, and then every 2 months thereafter. In terms of storage, the kits will often arrive by cold chain supply. IM rilpivirine must be stored in a refrigerator at 2 to 8 degrees centigrade. And it's noteworthy that long-acting cabotegravir does not require refrigeration, but it's often co-packaged in the same box with long-acting rilpivirine, and requiring the entire box to be refrigerated. It needs to be removed 15 minutes from the refrigerator to reach or to warm to room temperature pre-administration, and IM rilpivirine cannot be refrigerated again. And once it's removed from the refrigerator, it must be used within 6 hours. At the moment, long-acting cabotegravir and rilpivirine can only be administered by a healthcare professional. The oral lead-in is optional, and if given, it needs to be given 1 month prior to initiation of the injectables to assess tolerability. You need to consider BMI when selecting needle length. 23 gauge 1.5 inch needle is recommended, but the advice is to use 2 inch 21 gauge needles, which are not included in the package, if the BMI is greater than 30, or if there's increased fat distribution in the hips and buttocks. And this is supported by MRI findings findings of increased treatment failure in both men and women with BMIs greater than 30 using the shorter needle. It's important for staff to receive injection training. So ventrogluteal IM injection into the gluteus medius muscle using a Z-track technique, given on the opposite sides when possible, or at least more than 2 centimeters apart, if given on the same side. A dorsogluteal approach using an upper outer quadrant approach into the gluteus maximus is acceptable if preferred. And you need to observe the patient for another 10 to 15 minutes post-administration. Injection site reactions, the most common is pain or soreness at the site. The first injections are generally most painful, and they decrease over time. It is noteworthy that there's very little information in the patient information leaflets regarding what to do with these injection site reactions. Across a number of studies, the majority of injection site reactions were grade 1 and 2, and the median duration was 3 days. 2% in the 2 monthly and 3% in the monthly participants in the Atlas 2M study discontinued due to injection site reactions. How do you manage these? Well, ice packs, warm packs, non-steroidals or paracetamol, they become problematic. After injections, it's important to avoid strenuous exercise for 2 days, but you should encourage movement. And what goes a long way is if patients are told and advised about this beforehand. Moving on to long-acting ART self-injections, there's increasing evidence that injecting into the thigh, the lateral thigh or the vastus lateralis, is supported by PK parameters across both studies in both AIDS 2022 and CROI, which essentially show that the PK parameters are similar across thigh injections and in gluteal injections for long-acting cabotegravir and rilpivirine, and do not result in lower concentrations of either drug when injected into the thigh. The number of injection site reactions more or less are similar, whether you inject into the thigh or in the gluteus region. Scheduling injections, the date of the first initiation injection becomes a target treatment date. Pick a date between the 1st to the 28th. The injection window will be 14 days around that, and the dose can be given 7 days before or 7 days after the target treatment date. If the patient plans to miss a scheduled visit by more than 7 days, it's important to bridge the patient with oral cabotegravir and rilpivirine. If that's not available, then with any other oral suppressive treatment, which may be used for up to 2 consecutive months to replace 1 missed injection visit. In terms of monitoring and follow-up, HIV viral load should be repeated 4 to 8 weeks after switch to long-acting cabotegravir and rilpivirine, and after unplanned missed visits or delayed dosing. If viremia develops, test for resistance, and oral bridging therapy should be made available for planned missed visits. Now, injection dosing recommendations after unplanned missed injections by 7 days are available in the HHS guidelines as well as in the product information leaflet. So you can refer to this for that, but I will just talk a bit about the what to do if you miss doses in the 2 monthly dosing. So if the second injection dose is missed, and this is more than if this is less than 2 months since the last injection, you just resume that prior dosing schedule. If it's more than 2 months since the last injection, you initiate the dose, followed by another dose 1 month later, and then resume every 2 months. If the injection that's missed is injection 3 or later dose, if it's less than 3 months since the last injection, resume the prior dosing schedule. If it's more than 3 months since the last injection, initiate that dose, followed by another dose 1 month later, and then resume every 2 months. When stopping, transition to suppressive oral regimen within 8 weeks of the last intramuscular dose. Now, Long-acting carbapenem rilpivirine is clearly a game changer in the HIV treatment armamentarium. However, there are many limitations which limit the scale-up of this. And this is amongst some factors such as, and it's very well articulated in this blog by Paul Sachs in the HIV and ID observations. So some of these are complex logistics to implement and monitor. It's clearly that often we require somebody to champion this implementation. The real risk of treatment failure with resistance, as we mentioned a couple of times already, even with adherence to the regimen, costs, injections needing to be delivered by a healthcare worker, the frequency of visits, injection site reactions, and limited data for certain patients, particularly those with viremia, history of treatment failure. And this is also reflected on the side, and particularly with reference to low and middle income settings, where we have to consider other issues such as hepatitis B co-infection and concurrent treatment with TB treatment, particularly rifampicin, which can reduce carbapenem rilpivirine exposure. But other implementation considerations that need to be considered include costs, drug availability, the need to screen for hepatitis B prior to switch, the requirement for baseline resistance testing, the cold chain requirements for long-acting rilpivirine, healthcare provider system and strengthening, whether healthcare providers are acceptable in the first place, the infrastructure and the ability to deliver at scale. Long-acting ART implementation is, of course, a conflict with current differentiated service delivery models where patients are used to coming back every 6 months. And so this needs to be taken into consideration. And oral bridging for missed injections. And in fact, it may be more cost-effective, as been shown by some modeling data, to target populations with poor adherence and viral load of more than 1,000 copies per mil, but clearly we're not doing this currently. There are a number of implementation studies from real-world data which have basically studied implementation outcomes and reported strategies for successful clinic implementation. This is from Customize, which is a US-based study. It's a phase 3 implementation effectiveness study from 26 providers from 8 clinics. And essentially what they found was that healthcare staff found that long-acting carbapenem rilpivirine was acceptable, appropriate, feasible, and sustainable to implement across a number of diverse US-type clinics, with most feeling that optimal implementation was achieved in 1 to 3 months. The barriers to implementation amongst healthcare professionals, whether it was perception of patients' ability to keep monthly appointments, concerns around missed visits, staff resourcing, all reduced from baseline to month 12, as you can see from the right. And some of the key strategies for successful key clinic implementation included good staff communication, teamwork, use of a web-based treatment planner, and as well as good communication, particularly around the dosing window, having a good, effective appointment reminder system, and designated staff just for appointment tracking. Long-acting HART clearly has a role, as we can see, has been shown to be highly effective in virology suppressed patients, but it may have a role in those who are not virologically suppressed, where the need, in fact, for long-acting HART may be the greatest. And this is has been presented on a number of times by San Francisco's Ward 86 Safety Net Clinic, which largely included publicly insured patients with adherence issues and high rates of comorbidities, including mental illness, substance use, and unstable housing. They used a very rigorous protocol where the patients had to come to clinic every 4 weeks, had to be agreed to be reviewed bi-weekly with outreach from staff and significant support services. Out of the 133 patients, 74% had on-time injections, 76% with suppression at baseline, all maintained suppression through follow-up. On the other hand, 43% with patients at baseline. Out of 57 patients with viremia at baseline, 55 achieved viral suppression at a median of 33 days. 2 had early virological failure, which equated to about 1.5% virological failure rate, which is essentially similar to 48-week clinical cohort trial data. Now, moving on to lenacapavir for heavily treatment-experienced patients is a new capsid inhibitor and has been approved for heavily treated patients with viral failure in combination with optimized background regimen. And basically, this is Capella, which is a 2-cohort phase 2/3 trial data, which looked at patients with multi-drug resistant HIV, 72 patients who are in 2 different cohorts. The randomized cohort, they were randomized to oral lenacapavir or placebo with their failing regimen. for about 14 weeks, and then subsequently switched to subcut lenacapavir and optimized background. You also had another non-randomized arm, which was open label, where they started with oral lenacapavir and optimized background regimen, then switched after 14 days to subcut lenacapavir and optimized background regimen. The primary endpoint was a more than 5 log decline in HIV RNA. Lenacapavir achieved it in 88% of the patients versus placebo, only 17% at day 14 in a randomized cohort. The current analysis looks at efficacy and safety outcomes through week 52 in both randomized and non-randomized cohorts. And what we can see essentially is that 78% of patients achieved a HIV viral load of less than 50 by week 52 overall in both cohorts. And this, the efficacy in both cohorts did not really differ hugely by the number of active agents in the optimized background. 9 patients did develop resistance of those who reached 9 patients did develop resistance. Now, lenacapavir is given either as 300 milligram tablets or subcutaneous lenacapavir is given in a 1.5 ml vial, delivering 463.5 milligrams of injectable drug. There are 2 dosing options, and both dosing options you can actually see in the product leaflet. This is an alternative dosing option to the one in Capella, where you give 600 milligrams in day 1, with the subcut injection of 927 milligrams, and then day 2, another 600 milligrams, and then 6 monthly 927 milligrams of lenacapavir thereafter. This is the regimen which was used in the Capella study. You used which was initially preceded by an oral lead-in of 600 milligrams of oral lenacapavir on day 1, repeated at day 2, and then at day 8, you have a lower dose lenacapavir of 300 milligrams, and then at day 15, you have 2 vials of lenacapavir, and then repeated every 6 months. Just a couple of slides. Now, some of the practical considerations for lenacapavir. It's recommended to be administered by a healthcare professional. It is a substrate of PGP, UGT1A1, and CYP3A. It's contraindicated with strong CYP3A inducers. It needs to be stored at room temperature, and as we've seen, an oral lead-in is required. It's a yellow solution, and it should be inspected for discoloration prior to administration. It's given as subcutaneous injection 2 inches away from the navel, and it's important to rotate injection sites with each injection. Injection site reactions are common with up to 30% of participants, mostly were grade 1 or 2, and was less after the second injection. Swelling was the most common injection site reaction, and there were a low number of discontinuations due to injection site reactions. There's some data to support lenacapavir, emerging data in treatment naive, which I will not go through. I just wanted to conclude, you can't have a talk about long-acting ART in the Asia Pacific without talking about excess, particularly in the Asia Pacific. And almost all countries which have approved cabotegravir and rilpivirine for treatment, as we can clearly see, are in the high-income world. More specifically around the Asia Pacific, Singapore and South Korea now have recently received registration, but these number of countries remain very low. And in comparison to cabotegravir long-acting for prevention, access to long-acting injectables for HIV treatment lags behind. And this is largely also because we're not clear whether injectable rilpivirine will be available as a generic. Its patent expires in 2027. No current WHO recommendations on its use, as opposed to long-acting cabotegravir, which now has already signed sublicense with 3 generic companies to produce generic productions of long-acting cabotegravir. So with that, that was my last slide, and I'd like to thank everyone for allowing me to present today, and apologize if I've gone over slightly today. And with that, I'd like to acknowledge the people on the slide and happy to take any questions. Thank you.